us again for another episode of Health Talks with Dr. Trinh. The one show, maybe the only show, that tries to make sense of all the noise and give you a healthy way to live going forward. With the man who's always looking forward, I'm always looking forward to it at least. I'm always looking forward to his forward talking. Dr. Trinh, welcome, sir. A lot of forwards there. Hey, we've got something special today here. Not that the other shows weren't special, but you got a big get today here. Introduce your guest.
Yes, definitely. We have Elizabeth Lee, who is the director of the CAL OPTIMA PACE program.
Aha. And what is the PACE program? Well, maybe we should ask her. Welcome in to our guest, our mystery guest here. What is the PACE program?
What is CAL OPTIMA?
Yeah, what's CAL OPTIMA first? That's a bigger question. Let's set the ground. CAL OPTIMA is huge, but I'm not sure everybody instantly recognizes the name and knows all they do. What does CAL OPTIMA do, and what do you do in the PACE program?
Sure, and I just have to say I love the intro. I'm very inspired right now with Dr. Trinh. Thank you for having me on this morning. CAL OPTIMA is Orange County's Medicaid health plan.
Right.
We insure 1 in 4 Orange County residents.
Oh my goodness. 1 in 4? Did you know that, Dr. Trinh? 1 in 4? That's a lot of people. We got 3 million plus people in the county here.
Yeah, the low-income children, seniors, disabled members of our community are covered by CAL OPTIMA. CAL OPTIMA has been operating for the last 25 years, providing a continuum of care of payer services here in Orange County. And about 7 years ago, our community leaders who lead our board of directors started a PACE program that really is focused on serving the elderly, most frail members of our community. So PACE is an acronym. It stands for Program of All-Inclusive Care for the Elderly. The model started in San Francisco decades ago, but CAL OPTIMA started the first program here. And it's integrated care. It's your doctor, it's your nurse, it's your social worker on one location. That's also your health plan. So it's integrated care at its best for nursing home seniors that want to remain living in the community. So we help our seniors do that.
I had no idea there was such a program. My late parents passed away a few years ago, a number of years ago now. My aunt, my mother's maiden aunt, fell to me to take care of her as well, and she died in her 90s and eventually in a nursing home. And I was just flabbergasted how little there was in the way of information, how little there was in the way of help. This was out in Riverside County, out in Palm Springs. I just applaud you what you do. Talk a little bit about what you, before we do that, we have another guy joining us here. Welcome, Dr. Miles. Looks like you made it in, sir. Are you with us? He's connecting to audio right now here. So before he comes in and we get them all going here, expand upon that. What kind of services do you do with integrated care? What does that really mean?
It's everything that you're going to need to be safe at home while you have complex medical conditions. So it's your doctor, your nurse, it's home care, meals delivered to your home. It's the transportation. You see all these vans. It looks like I'm standing in the parking lot.
You are, yeah. You're washing the vans this morning. I figured you had to get them ready to go out there. Yeah.
That's right. That's actually what our parking lot looks like. These vans, right now they're delivering supplies, equipment, medications. It's complete healthcare. And most people, when they hear about it, they think it's too good to be true.
That's exactly my reaction. It's too good to be true. Come on. Because really what I discovered, I'm an only child, taking care of my elderly parents out in Palm Springs, and then my maiden aunt who had nobody but me, is you're on your own in most parts of the country when it comes to taking care of the seniors are on their own. And if they do have a caregiver or a loved one helping them, they're on their own. They're stressed. They're strapped. They don't know where to go and where to turn. And I would turn to the doctors, I'm sorry to say, Dr. Trinh, and they would say, I don't know, figure it out. But I don't have time to tell you how to get them a meal or get them bathed or get them to take their medications on time. That's up to you to figure out. All I'm telling you is your loved one, your elderly one, is very frail, very sick, and probably shouldn't be living by themselves. And you're like, I can't take him in, or they don't want to move in with me, and they have no money to move into an assisted living facility that starts at $4 or $5 grand a month. So what do we do? And everybody would just shrug and go, figure it out. It was shocking. It really was. So welcome to Dr. Miles, who made it. Miles and miles to go. He made it.
I made it.
So introduce yourself, and where do you fit into this? We were talking about the PACE program. Where do you fit into Cal Optima?
I'm Dr. Miles Masatsugu. I'm one of the medical directors at Cal Optima, and I'm the PACE medical director. And I've been with the program since it first started.
Okay, so you're associated with the PACE program as well. Again, is this rare? Are there PACE programs all over the country that I just know about, or is this a rarity, one of the few?
No, there's PACE programs all over the country, but they're all pretty small. And currently, this is the only program in Orange County, although there are a couple more that are coming up soon. Currently, there's only one program in Orange County.
And it's only administered through Cal Optima. So there aren't any private organizations. I think of, or even a charitable organization, I think of Meals on Wheels. Is this something that they supplement and do a little bit of what you do? They provide food, or do you work with them? How do they coordinate all this stuff together here?
Well, the Cal Optima PACE program is run by Cal Optima.
Right.
We run the entire program. We provide all the services. So yeah, currently we're the only program in Orange County, and then we coordinate all the services by ourselves.
And so again, what services do you do? Let's just go through this again. She said it before, and I'm still trying to wrap my head around it. If I get into the PACE what's it take to get into the PACE program, and what do you do for those people?
Okay, so to be eligible for the PACE program, you have to be 55 years and older.
Okay, I make that.
You have to be living in Orange County.
Okay, I got that.
Very good. You have to be nursing home eligible by the state of California.
And
now,
what
that means is, I'll tell you what that means. So typically, it's someone who has a number of chronic diseases. Someone, for example, a lot of our patients have diabetes, high blood pressure. Mm-hmm. A lot of half our patients have some form of dementia. And normally then you need some bit of help with what we call your ADLs. So maybe you need help bathing. Maybe you need help shopping for food. So there's some basic element there that you need some kind of help.
And Dr. Trinh, what's an ADL?
Activities of daily living that you need some kind of assistance, whether it's eating or cooking.
What are aren't there like 5 of them? What are the 5 ADLs?
Yes.
Maybe Elizabeth will tell us. What are the 5 ADLs? I'm trying to remember. I had to learn this when my aunt was so ill.
Eating, showering, dressing, ambulation, transfers, and then you have your IADL. So it's your ability to use the phone, balance a checkbook, all of those additional skills.
The one that you just so casually threw in there, ambulatory, to be able to get up and go to the bathroom on your own, to be able to get up and go to the refrigerator. I didn't realize how critical and huge that was till I saw my own parents struggling with that issue. It's what finally ended my mother's life. She could not get up and go to the bathroom, and she was so weak that she got pneumonia and just died. I mean, her whole system was so weak. My father fell trying to go to the refrigerator and got a brain concussion, and that's what finally ended his life. He didn't die from the leukemia that he'd suffered with his whole life, or the aneurysm that almost took his life. He died because he fell going to the refrigerator. And my late aunt finally had to go into a nursing home, even though she didn't have the money, because she couldn't get up and go to the bathroom by herself.
Is there a financial eligibility criteria to participating in PACE?
That's a good question.
Elizabeth, you want to take that?
Do you have to be very poor or a certain amount of income?
No, sure. I think, Paul, the story you just told, the tragic experience that you had, I think it's really unfortunately common. I hear that quite a bit, and people who wish they knew about PACE earlier. I think that's a common story.
Right.
But individuals who are eligible for Medi-Cal are eligible to come into PACE with no premium, no co-payments, no deductibles. Individuals who are Medi-Cal and Medicare eligible also have the same option, and there are also private pay options as well. So
there are private. So if you decided, if you weren't, if you had more money than, that would probably be me or many others. We don't qualify for Medicaid, but we may not have all the money in the world. We could pay to join the program.
Yeah, there is a premium associated.
Okay, well, that's cool.
Got it.
All right, and so again, let's explore that ambulatory issue. So what do you do to help people who can't make it to the bed? They're in their home, they're trying to stay there, either because they want to, probably because it's a burden to go somewhere else, to family who are all working. My wife and I used to say, okay, I guess we could take my aunt in, but who gets to stay home? Who gets to quit their job and take care of her here? And how do we make that work? And she didn't want to hear about it anyway. That was the last thing in the world she wanted to do. She wanted to be independent. She wanted to stay at home. And I will say that when she finally did we got her into a, someday you should talk about these, Dr. Trinh, these group homes. It's the only thing she could afford. Somebody rents a private house and they watch 4 or 5 of these patients, which I thought was a wonderful thing. Another thing I never knew existed. Not a giant facility that charged $4 or $5 grand a month, but something that charged half of that. And when she finally got there, she died very quickly afterwards. And I think part of it is just she just lost her will. She wasn't independent for her whole life. She never got married. Whole life she was independent, and now she was forced to live in somebody else's home, as she said, whether it was my home or their home, and she just withered away. I can't prove she died because of that, but she didn't die very long after that.
Yeah, I mean, I'll tell you something. I mean, you ask anyone, everyone would much rather live in their own home. I mean, there's just no question about that. And so some of the things that we're able to do, as an example, our participants who enroll in our program, we can bring them to the center. We provide transportation everywhere, so we can bring them to our center multiple times a week. And it's kind of like an adult day center where there's a lot of socialization that happens there. And in addition, when they're at the center, a lot of the care comes to them. So at this center where they're socializing with their friends, we also have physical therapy, occupational therapy, speech therapy. The clinic is on site. Specialists come there. Dentists come there. We have an optometrist that comes there. So everyone comes to them. And if they need help at home, we are able to send people to their home to help. When we order medications, when our doctors order medications for our members, we have our own pharmacy who kind of fills that, packages that. We have our own pharmacist who then delivers it to their home. And so, like I said, everything is brought to them. When our doctors see them and they say, I'm going to order this test, I want you to see this doctor, our team coordinates all that. So we schedule the appointments. We schedule the transportation. If they need a translator, if they need someone to go with them, we do all of that. We coordinate all that care. And so, yeah, I think it's a total wraparound program. I think one of the advantages of the program that makes it very different is that because our members come to our center multiple times a week to kind of socialize, our doctors, our providers are able to see our members frequently. They see them all the time. Like literally they can see them multiple times a week if needed. And so if there's any small change in their medical conditions, we pick it up immediately. And we're able to immediately put in interventions. So yeah, it's kind of a full service wraparound. Now, and I'll tell you something else which makes it a little unique, I think, is that as a program, when our members see our doctors, they'll see them in the clinic. If they go to the hospital, they see the same doctors. If they go to the nursing home, they see the same doctors. So we have really good coordination of care. And again, it makes us a little bit unique, I think, compared to other programs out there.
Let's do a shout out to one of the listeners on Facebook here, Alex, who I think Dr. Trinh knows. Alex Lecky says, my wife's career is in helping people with disabilities that can't live on their own. and help them deal with these challenges of daily life. There are people out there, I forget what they call them, visiting angels type of programs and stuff that you can pay for and get people to come out and do this. But I just got to comment on what you said, because in real life, I saw it up real close. I didn't see it so much with my mom and dad because they had each other. And my dad became my mom's caregiver in the last few years and dedicated 24/7. She had Parkinson's, she had Alzheimer's, and they were able to stay in the house because he basically did everything for her. And it was only when he couldn't lift her up anymore to go to the bathroom that they finally talked about putting her into a facility. But by then she was so weak, she couldn't get up, she couldn't move, she couldn't walk, and it didn't take much to take her life at that point in time. My dad was another case. He was pretty independent until he started falling, and the fall is what killed him. My father used to grimly ask me all the time, I wonder what's going to take my life. And I'm like, Dad, we're not going to have this conversation. But he would say, well, is it the leukemia? Is it my heart? He had all these things through life. None of that. He breezed through major heart operations and everything else. It was falling, trying to pull something out of the refrigerator and banging his head on the counter. And it suddenly, a brain injury developed and a blood clot and everything else. And it was horrible. A fall is what killed my father. And then my aunt, who survived both of them, stubbornly held on to her little apartment. And I'm telling you, she lived out in Palm Springs. I live here in Orange County. I would go out once a week to visit her. I was the only human being that saw her, other than her beloved Meals on Wheels guy who came every morning to just give her food and see that she was still alive. Other than that, she didn't talk to anybody. She didn't see anybody. So nobody got to see. Once a week, I'd sort of say it was not the best. You know, somebody should have been seeing her more often. She became very isolated and very withdrawn. You can imagine. She saw nobody. She was a hermit. She lived alone, unhelped, unknown, in the midst of an apartment complex. Nobody even knew she was there. And so she didn't see doctors very often. And when she did, it was a huge deal because I had to come get her. And she was huge, and she was hard to move around, and she was weak. And so getting her in and out of the car was a nightmare. It was horrible. She'd panic that she was going to fall. I'm falling. And I'd say, you're not falling. It's okay. And you think I was beating her with a stick. You know, she'd start screaming and crying. She'd say, I'm sorry, but I'm just so frightened. And so all of those things you're talking about, isolation, checking in on them, socialization. Wow. I wish maybe there is a PACE program out in Palm Springs area. I didn't know there was one, and nobody certainly clued us in. And we went on for years like that. And I thought, what a terrible existence. Fighting to, I'm going to get choked up here, fighting just to stay, not just to stay alive, but to stay independent in a world where she was pretty much forgotten and overlooked and on her own.
So this program reduces hospitalizations and rehospitalizations and readmissions. If you got somebody who's keeping an eye on you on a regular basis and looking at your vital signs, and you got nurses on site and doctors on site, it is a way to really provide that continuity and comprehensive care that we all need. And so PACE is a model of that works very well, because you know, right now it's so truncated in healthcare.
Yeah,
right?
It's all broken up.
Primary care, you got all your specialists. You end up in the hospital. You got different, hospitalists seeing you. It's very truncated and with poor communication. So, and
it's got to be more cost effective, because I'll tell you what my aunt used to do, and it drove me crazy in the healthcare system. But when she would get too scared and too panicky, usually like 2:00 in the morning on a Wednesday, and I'm here and she's there, she would call emergency. And she would have, or she'd have the police come out, and the police would come out and say, well, what do you want us to do? Well, I can't get to the bathroom. We're the police. Well, but you can do anything. Or she would call 911, and a couple of times, because she couldn't get to the door, they had to break the door down multiple times to her apartment to come in, took her to the hospital, sat there for 4 hours in emergency, and the doctor finally said, what do you want me to do? You're old. You're weak. You can't get to the bathroom. Well, fix me. There is no fix. And she's seeing somebody every time and over again. It was maddening, but she didn't know what else to do.
Yeah. I'll tell you something. One of the things we're really proud about is that, so all of our participants in our program technically could be living in nursing facilities, but they don't. They live at home. And that's kind of one of the main goals of our program, to allow people to live at home as long as possible. And right now, I think we have, less than 1% of our participants live in nursing facilities. But if a participant eventually down the road, many years later, needs to go in a nursing facility, our program covers the cost. And again,
it covers the cost.
That's right. And there's no limit. There's not a number of days. It doesn't expire. If you need to be in a nursing facility, our program will pay for that, and it'll pay for it for as long as you need it.
I'm flabbergasted, and I got to challenge you on that, because my wife and I went round and round trying to figure this out for my aunt in particular here. And the problem was, like, she would get ill. She had a rare form of blood cancer, so she was very weak and very anemic all the time here. It was called Waldenstrom's. It was a rare, one of these orphan diseases for which there is no real treatment or protocol or anything. Anyway, we would get frustrated because she would eventually get so sick that she'd have to go in the hospital. And as we all know, Medicare's job is to get you out. They don't want to, it's cost effective, it's psychologically effective, it's everything. And so, and then she'd go in the hospital a couple of days, then they'd put her in a skilled nursing facility that Medicare would pay for up to 30 days if you could see progress. And then goodbye. And I'm like, goodbye? What do I do now? I don't know.
Yep.
But the door's over there, and you got to get out of here tomorrow. Time's up.
Yep.
So you guys will pay. And then, again, we went to assisted living facilities. There's assisted living, and then there's the other one, whose name escapes me, where they take full care of you, a nursing home. And
nursing home, yeah.
The price started in Palm Springs, $4 or $5 grand. That's where it starts.
Yep.
And every time they touch you, they got to take you to the bathroom. They got to help you with the pills. Let's add another $500. Let's add another $500. My aunt was living on $2,500 a month, pension, Social Security, the whole thing. How could she pay? So if she were alive and she were here, you would say what? You would say, we'll pay for a skilled nursing facility for as long as you need it, or we'll pay for a nursing home as long as you need it. We'll pay that $4 or $5 grand.
Yes, if she's in our program and she needs to be in a nursing facility, yes, our program would pay for it.
Oh,
and again, there's no limit.
Oh my goodness. Where were you?
Yeah.
I think the important thing is that we're so motivated to keep people in their homes. So we will provide so much prevention and home modification training to the caregivers, in-home care, because I think that we touched on independence earlier. That's such a key word. I think some of it, we forget how independent we are and make our own meals, drive to work. But when our elderly family members can no longer do that, I think that's where this model comes in, and whatever's medically necessary.
And the smallest things become the biggest barriers. My aunt couldn't maneuver over the little threshold that gets into the bathroom. That little bump where it separated the linoleum from the carpet was like Mount Everest to her, climbing over that with her walker and everything else. The smallest of activities were difficult for her to do because nothing was set up in her apartment to accommodate a senior with a walker.
Wow. How have you pivoted for coronavirus?
Yeah.
Pandemic?
Sure, I'll take that one, Dr. Miles. I think that we look incredibly different, like the rest of the world right now, related to the coronavirus. We realized very quickly that a senior congregate setting, individuals sitting close by, having meals together and socializing, doing activities, was not going to be safe. So our program, our center, which is where all the services have been provided for years and years, is now closed to visitors. Our clinic remains open for medical services and our rehabilitation. So our physical therapy and occupational therapy is available for acute services right now. But other than that, we've taken our program out into the community. So we are now doing most of our visits and encounters by telehealth and over the computer, over the phone. We have wellness callers. Our staff of nurses and social workers are checking in weekly, sometimes multiple times per week with our participants, asking them, did you get out of bed today? Yeah. Did you eat today? Did you take your medications? Did you get dressed? just checking and making sure that people are moving forward even during these difficult times. And then, of course, the vans, our vans aren't just sitting in the parking lot these days. They're out on the road, checking in on our participants, delivering food, supplies, medications.
How do you pay for all this? Is this a government-funded program? Is this a grant? How do you get?
It's a joint program. It's funded by Medi-Cal and Medicare, so state and federal funding combined.
And again, is there a program in Palm Springs, Riverside? Did we just struggle for years and not know about this, or?
There is now.
There is now. Okay.
There is now.
little late for my aunt's case here, my parents' case. It was a number of years ago. All right, so go ahead, Dr. Trinh. I just got to ask one more question here, and then I'll let Dr. Trinh take, because this is so near and dear to me. I lived this. What kinds of risk are seniors at, the people in your program, because of COVID? I hear such wildly different statistics. In fact, I heard one the other day, and again, I don't know, I got it wrong like everybody else does, so I'm probably floating misinformation, but it was something like people over 70, of which I'm soon to be, in a few years. People over 70 have some shocking number of 20% of them, 30% of them that get infected are going to have to go into the hospital. And of those, a shocking number are at risk of dying or are going to die from COVID, because we've got all these comorbidities, we've got all these problems of age and everything else here. Give us some real statistics. Give us some real information about how vulnerable is your population. Because many people are saying, let's just all get it's like the flu. Let's all get it and get it over with. It's no big deal. I don't have to worry about infecting anybody. I'm not going to die. It's 99% safe. And so why are we shutting everything down and worrying about all this? And I wonder what the other side is. What is the real risk to these 1 in 4 people in Orange County that you're taking care of?
Yeah, so I'll just say that we have the opposite thought process. I mean, we certainly have our participants specifically are at a very, very high risk for a couple of reasons, not just because of age, but because of age, and by definition, they have a lot of medical issues, like typically diabetes and high blood pressure and had strokes and all the rest, and a lot of lung problems or a lot of pulmonary problems, which is one of the bigger issues. And so when our participants have gotten COVID, because we've had some that have had it, almost all of them, most of them have been hospitalized.
Wow, most of them.
And there is a high mortality risk once they get that. So we are very, very careful right now in everything that we're doing, just because of how high risk our participants are if they were to get it.
So what would you say to those in our community, some of whom may be listening today, who say this is overblown, we're overdoing the protection, go on with your life, wear your mask, yes, distance yourself, but don't worry about it. If you get it, it's no big deal. It's a bad case of the flu, and let's just get it over with and get on with our life. Some people, I hate to say this, are saying we're shutting down the entire system, and people are going bankrupt just to protect a handful of few people who are at risk. I know that's horrible to put it that way, but that's the way some people feel.
Yeah. And I would say that we're seeing kind of the consequences of some of that right now, in that the number of cases have kind of skyrocketed in the last couple of weeks.
Huge. Yeah.
And the challenge is that the hospitals, and more specifically the ICUs, are getting full. And as there is a chance we could reach capacity within the ICU, which means that when people get sick for other reasons,
right,
stroke, heart attacks, there's nowhere for them to go. And at that point, it's going to get really dangerous. And so it's not even just COVID, it's our hospital and healthcare capacity, the system capacity, that's really important right now. And so it is really important for everyone to kind of wear masks and try to be socially distanced and do the basic hygiene. I think if we could all just do those basic things, what it does is it will put some relief on the healthcare system as a whole, so that if you were to get sick with something totally unrelated to COVID, you can go to the hospital and get care like you normally would.
So you won't die from a heart attack because you couldn't get, if you could have a heart attack and not be able to get that care you need and die needlessly. People could die who otherwise could be saved simply because there was no room at the inn.
Yep.
What do you
Yeah.
think, Dr. Trinh?
Yeah.
What are you seeing? You're in the memorial care and everything. What are you seeing right now? Is it the alarm bells going off like they should be, or are we still living with our head in the sand?
The alarm bells are going off at our hospitals. Lots of patients often stuck in the ER, although they've been admitted, because there isn't any room in the rest of the hospital or in the ICU. And so now you have limited capacity in the ER because nobody else can get in. And so it trickles backward. And so what's happening is a lot of ambulances and paramedics, they're getting diverted from hospital to hospital as these emergency rooms fill up. And
so they show up and they say no room, and they say go down the street, go to the next hospital, and they load them back in. And
yeah, access is a domino effect, lack of access, and that's what we're seeing now at the hospitals that I work at.
I'd be curious to poll your listeners right now. We'd love to get them involved in this stuff here, because we've talked about this endlessly since the COVID began. Is it real? Is it overblown? Is there a real danger, or just to a few? And is it worth the pain of shutting the economy down and the bankruptcies and the difficulties and all the other stuff to save those few people here? That's
so
a harsh decision.
Your PACE centers, the PACE centers, is it one centralized center, or do you have multiple throughout Orange County?
Right now, we have one central center in Garden Grove, and then we have satellite sites. So Paul mentioned the Meals on Wheels. We actually partner with them as we have 5 satellite sites: Alzheimer's Family Services in Huntington Beach, 2 Meals on Wheels sites, one in Anaheim, one in Santa Ana, and then 2 Alzheimer's OC sites, one in Laguna Hills and one in Garden Grove.
The Acacia Center, right?
Yep, that's right.
Yes, I'm the medical director for that one.
What? You're everything. Every time you guys somebody it gives me another credential. Well, and I also do this, and I also on the side cure cancer, and I also do this. I
love seeing the PACE clients come in, and it's like once a month, right? We get together with the interdisciplinary team, and we have another PACE client, and we're like, yeah, and I can totally see how these centers reduce hospitalizations by providing that. If you walk into an adult daycare, if you're diabetic, your sugar is checked, if you need to, your blood pressure is checked every day, and your vital signs are checked, and any abnormalities get sent to the primary care physician for a coordination of care. And man, we don't have enough of these centers.
Yeah,
it's like huge. It is the answer to reducing hospitalizations.
And that's the end goal. It saves money. It lengthens your life. It's a better quality. I mean, nobody wants to spend their last years living in a hospital bed.
No.
Yep.
So
I'll tell you something else that's interesting in our program. Our doctors typically have a panel. That means, how many patients do they take care of? A typical doctor in the outpatient setting, it's thousands.
Yeah.
Our doctors on average take care of about 100 patients.
Wow.
That's it. 100. They see our patients frequently, and the visits are long. They take their time when they see them. So it's the not just the quantity, but it's the kind of the quantity and the quality of care that they're getting is really intense.
So again, can I talk about how rare that is from my own parents and my own aunt's experience? My aunt used to drive my dad crazy, and he would go to see a specialist. He had leukemia, and he had blood cancer, so he would go see periodically a doctor. And it was hard to even get to see the doctor anymore. They would just give him to the nurse practitioner, the lesser person on the rung here, to check his whatever levels and glucose levels or something here. Not glucose, whatever it was. I forgot the thing he checked every week here. His white blood cell count, I guess. And it drove him crazy how quickly he was in and out. How do you get to know me? And in one case, the doctor started writing the report before he'd even finished talking to my dad. So he's in there dictating his notes, and my dad's like, "Do you want to talk to me first?" Well, I observed patients here. He's doing this. I've read the report, everything else there. They're in and out in minutes. Talk about that, Dr. Trinh. I got to go take care of one other thing here, but talk about how quick patients see people and how that drives older people crazy and probably doesn't give you the best results.
Yeah, no, there's been national surveys where a patient in a primary care office gets about 7 minutes with their doctor, and that's true. It's although you may be given 20 minutes, half of that time is often taken up by the nursing staff taking care of your vital signs and reconciling your medications and things of that sort. So by the time the doctor walks in, you've got about 7 or 10 minutes left. So great program, Miles. And get this, this is not scientific, but I'm with Alzheimer's Orange County, and so when I go to Acacia to once a month for our interdisciplinary team evaluations for new patients, new clients coming in, and reevaluations, the 6-month reevaluations. And so part of that includes the MMSE testing, right, to evaluate their memory and cognitive situation. It is not uncommon, and again, this is not a scientific study, but it is not uncommon to see an initial baseline MMSE when they first come in, and to watch those numbers improve 6 months later because of that socialization, that interaction. And I'm like, this is the best, this is the best non-Aricept, the best non-Aricept treatment you can have is to participate in adult daycare. Right? You know what I mean?
I totally agree. Yeah, I totally agree with you. I see the same thing. I think we see similar things in our program. Yeah.
Do we do more of this in other countries? One of your listeners, Diane Sparrow, I guess, is tuning in from the United Kingdom. She's in Britain, I guess, here. And she says she does live alone with various chronic diseases, but in their healthcare system, she has a lot of support, visiting nurses, visiting community matron, social and mental health workers. It's available nationwide because they have the ugly word socialized medicine, but they have a wider thing in our pay for care system. There is not an incentive. There's an incentive to keep the line moving, to see more patients in a practice, to get them in and out as quickly as possible, or on the government side to pay to get them in and out, because we don't want to. Time is money, so get them in and out, get them quick, short stays, short visits, in and out. I wonder if that doesn't, like Dr. Trinh saying, work against the success rate of the system. What do you think?
I'll tell you something that's interesting. I'll tell you something interesting about our program. So, people have always talked about, you got to spend money on preventative care. You got to spend money on the front end, and you'll save money on the back end. And I think in practice, it's very hard to do. Because typically, the people paying for the care don't pay for the care for someone's entire life.
Right.
But in our program, we really do that. I mean, this is one of those programs where we really spend a lot of money before people get hospitalized to keep them from being hospitalized. And that's why there's so many services and things available to our members, because our program is responsible for all costs. So if someone ends up in a nursing facility, we will pay for that. And so rather than do that, we would rather spend the money you had discussed earlier, the thousands of dollars on nursing care on the front end to help modify their home, to make sure they have someone going with them to visits if they need an escort, to make sure they have transportation, to make sure they have their meds. So we spend a lot of money on the front end to prevent people from having to go in the hospital. And because our program is responsible for all costs, we can really make it work.
How careful, how do you transport people to talk about Elizabeth? You got all these vans back. Because again, I'm going to tell you lots of horror stories. I got lots of them. We could talk for hours about the horror stories and what I learned about the healthcare system, taking care of seniors, being forced to take care of my mom and dad to some degree, and my aunt to total degree. And here's one that drove me crazy. Because she was in a Medicare Advantage plan at the end, the advantage was they would pay for transportation. We could never use it because the transportation was a guy in a car, a kid in a car, who came out to pick up my heavy aunt who could barely move in a walker. And the last time we tried it, where somebody came and took her to the doctor midweek, they ripped her leg open. As she put her leg into the car, pushed her in the car, her legs would split open so easily, they're all blown up with fluid, and she ripped her leg open and had to go in the hospital. The transportation almost killed her. And they wouldn't have a wheelchair van available and everything else. So it was just a kid in a car trying to take my aunt someplace, and she was difficult, and she screamed, and she got fearful and all this stuff, and they didn't like it, and they didn't want it. And so we just politely pushed her and caused this problem. How do you move this population around? It ain't so easy. It's not just showing up.
No, for sure not. So the vans behind me, they're lift vans. So they have the wheelchair lift in the back. Inside the vans, they don't look like a normal passenger van. Some of them are modified to have fewer seats, or they'll have tie down so that you load a wheelchair, you lock down and tie down the wheelchair, and you can transport like that. We do have access to a small sedans. Some people can use sedans and get in and out of cars with a little bit of assistance, and that's
Right.
fine too.
Well, I can't tell you, all these little things added up to one big disaster when it came to it, and it changed my life. I had to basically take a day off every week, and that was the day I scheduled, not just to go visit her, I'd stay longer in the weekend, but I would take care of all these things. I knew how to get her in and out of the car. I knew how to handle these things after a while. But for me, I don't know how she could have kept going. I'm not saying that in a congratulatory way. I'm simply saying I was forced to step up and fill in a gap because there was nothing there. Nobody to care, to worry about anything here. How many people are out there like this, do you think? You said 1 in 4 people? That's a huge number.
The 1 in 4 is CAL OPTIMA members in
Oh,
the
okay.
county.
Right. Okay.
So when you look at individuals who meet the criteria that Dr. Miles explained, the 55 or older or nursing home eligible that want PACE, there's different estimates out there. They believe, like in the county, maybe 6,000 to 7,000 individuals, but then not everyone is going to want a program like this. So there's probably fewer that would want to enroll in a program that's this coordinated care. But it's a fantastic option for those individuals who are eligible.
Why would they fight it? Just because they don't want to be told what to do, or they don't think they need it, or?
Yeah, you know, not everyone wants to be part of this coordinated program. I remember my grandma, she refused to go to any kind of a senior center because that's where all the blue-haired ladies go. And I'm thinking, Grandma, your hair is pretty gray yourself, but it's not for everyone. One of the I think it's a benefit of enrolling in our PACE program is that you're going to receive your primary care services from our doctors. What that means is if you've had a family doctor for 30, 40 years, that you're not going to be able to continue. It's likely that you're not going to be able to continue seeing them. You're going to enroll in our program and be kind of wrapped around with our services. And that's, I think that's a decision for some folks, to be perfectly honest.
How do you tell people about this? Is it through the doctors? The Dr. Trins of the world say, hey, Paul, your aunt needs to go here? Because we didn't get any of that. Her doctors just shrugged and went, figure it out. I'm telling you, your aunt can't live alone. She needs this. Time's up. Out of here. And these doctors that she loved and had for years, I didn't have, quite frankly, a great feeling for any of them. They were just a machine. And in fact, the doctor that she so adored, who was her cancer doctor, who I won't point him out, but he was picked by, written up in the local paper out there as he had more patients and more money, millions he made from seeing cancer patients because he saw so many. He just cranked them through like in an assembly line. And I seemed like a nice guy the couple of times I met him, but it seemed like a machine. It seemed like a factory. And when she had to go finally into an Medicare Advantage plan, and he wasn't on the plan, he never called. He never said goodbye. One day he saw her. The next day they said, you can't come back. The nurse called up and said, sorry, we can't see you anymore because we don't accept that plan. And just like that, she was cut off after 20 years. She was horrified. She thought this guy really cared about her, and all he cared about was, in my opinion, an assembly line practice that made millions.
I would say that we're probably the opposite of that situation that you just described. I think this is like concierge healthcare.
Yeah, right. Sounds like it. And somebody else is paying for it. Oh my God. Why does this all sound too good to be true?
You know, what is surprising is that most physicians, including myself, have heard of PACE, but don't know all the different benefits and value that PACE provides. It's like I'm learning stuff today, and I've been in practice for like 20 years, right? And it's so valuable. Now, how does, so PACE have their own PCPs. How does a PCP...
What is a PCP? You got to define that.
Primary care provider, right?
Okay.
PACE have their own primary care providers. So how does a primary care provider enroll to be part of a, is it somebody who is employed by you or contracted by you, who can see other care as well?
Yeah, so it's contracted. We have contracted providers that work for us. I think that all the current PCPs are full time though, so they don't have a second. That's not true. Some do inpatient and outpatient work, but for the most part, their only outpatient work is with us.
Right.
And I think part of the challenge, so we've had other doctors in the community want to become primary care doctors with us and have actually started the process because we would allow that to happen. The problem is that the program, the number of patients is so small, right? Like I said, our doctors only have 100 patients. And so to have 5 patients is a lot of patients in our mind to begin with, as an example. And it's not enough for a lot of doctors. Like we've just discussed, a lot of doctors want a lot of patients.
Yeah, right.
And our program is more of a concierge, smaller program, more time intensive. And so we found that a lot of the community docs aren't as interested. But if they wanted to participate, it's something we would certainly look at. Yeah, and we've done it before.
Talk about that a little bit, Dr. Trinh. I don't want to put you in hot water with Memorial Care or any of your fellow doctors here, but am I wrong? Am I just cynical and jaded and negative because I loved my aunt and I hated to see what happened to her? But it seems like doctors have become almost assembly lines, and it's in and out as quick as you can, and they get these practice people that come in and magnify their practices, and they make tons of money, and it's all about staying on the clock and staying on time and in and out as quick as you can. Sometimes
it seems that way. Part of the reason primary care physicians are so busy, and it seems like they're always running, is because there is a shortage of primary care physicians nationally. There isn't enough of them.
Okay.
So you either try to accommodate as many patients as you can because of that shortage, or if you want to spend that 30 minutes to an hour with a patient, the next patient that calls in for an appointment is going to wait 3 months to see you.
Yeah.
Right. So there's a balance there.
Okay. All right. That's a worthy other perspective that I had. I'm just looking at it from my perspective here.
Right.
I don't know of too many. Do we do better jobs in other countries? We're also frightened of socialized medicine, of Medicare for all. I don't know why. Is it really that? Do you just get? I mean, I'm not. This is a broad question, but I mean, should we look at more of these county-wide, statewide, country of coordinated care? Or is this smack too much of government control and we're fearful and it's bureaucracy and you don't get as good a care? What do you guys say? I'm guessing you like with the programs you've got and would like to see it expand. But so here's your chance to make an ad for that.
Yeah, I will say that the PACE model of care is growing pretty quick throughout the country. So it is something that is right now not a lot of people know about because it's so small. Like the total number of people enrolled in this, they call it a model of care, is very, very small. Like in Orange County, there's only right now less than 400 people in this model of care.
Wow.
But it is growing pretty quickly throughout, not just Orange County or California, but throughout the country. It's growing fairly rapidly right now. And so I think people are going to become a lot more familiar with the term PACE over the next few years because it is growing as a model of care.
Because I wonder, we've talked about this show a little bit. I certainly will talk, as I'm doing here today, dominating the discussion, sharing bad story after bad story of my own experience. And I'll do this to anybody who will listen. People are like, okay, Paul, I got to go. But, I'm happy to tell everybody about what happened with my aunt and my mom and my dad, especially as I was going through it. Let me tell you what you're going to see. Let me tell you what you're not prepared for here. And what strikes me is we are hurtling towards another huge collapse, crisis, something here. The baby boomers, the wave. We're turning 65 at a rapid pace here, and we ain't ready for this. The good news is I'm going to live to be 95. The bad news is I'm going to live to be 95. I don't know how I'm going to take care of things and pay for it and do all this stuff.
Yep.
So how do you get the word out? First of all, I want to thank whoever sent us a press release. I think that's what started this whole thing. We're on your media list somehow, and somebody sent us a press release, and I said to Dr. Trinh, there's a story that we should be doing. And he jumped in and agreed and said, I think I can get a hold of somebody. I can do this and whatnot here. But it isn't a story that comes to mind. It's not on the front page. PACE, I didn't hear about PACE last week. I didn't hear about PACE wasn't in the news last month. How do you, in the midst of all these crises and all these problems, how do you keep your story front and center?
First of all, I will say that we will talk about PACE to anyone who wants to listen. I think Dr. Miles and I, we've been at this together for the last 7 years of talking about PACE and growing it in the community. When people hear about it, it's too good to be true. It's a lot to take in.
Right.
But we're working on getting the word out to our discharge planners at the local hospitals, to the nursing facilities. One of the greatest sources of enrollment from us is our families referring to their friends.
That I could see, yes. I'll
that's
believe
the greatest
that.
Compliment.
Amazing.
Well, I would suggest teaching more of the Dr. Trins of the world, because even he just admitted, hey, most of us don't really know that much about it. And that's where I started. I went to our doctor. I said, what do I do? And he shrugged and said, I don't know. That was terrible. Then they send you to some social workers sometimes, like when she was in a hospital, there was a discharge nurse, and she would kind of give you some things. And I say, what would you do if this was your aunt? And they'd go, and part of it is liability. I can't tell you. I don't want to tell you. I'm scared to tell you. Here's a list. Go call them. I can't make any recommendations because you'll sue me or something if I steer you wrong. A lot of that is just there's a lack of, I'm telling you, if I haven't told you loudly enough, there's a lack of information getting from you to the general public out here. The people who need the services don't know about it, don't know where to find it, and the people they go to ask either don't know or don't tell them, or don't tell them much. So,
no, we hear you. We're looking at different ways, especially during the pandemic, for people to see our services. So our vans are out in the neighborhood, billboards on bus stops. We're going to be doing some short videos and spots on TV. We had a nice little feature last month on ABC News.
good.
So we're working as hard as we can to get the word out, but opportunities like this definitely we sincerely appreciate, especially the conversation as well. This has been great.
Well, that's the power of this medium, is it's a conversational medium, and we have an audience here. We've had a very silent group of people today, Dr. Trinh, here. They just taken it in. Usually they're much more opinionated and asking questions here.
They're taking it in. We're all learning about PACE, and to many people, it's new. Yeah, we would love to promote what you do, because I totally see the comprehensive value in it, from the prevention side, from the front end prevention, as opposed to the hospitalization. And so we should definitely chat and look for ways to collaborate and get more folks at your doors. Would love that. What does we got like 3 minutes left?
Right.
What does it look like for the future of PACE? Do you have any new programs you're launching, or anything of that sort with the next few years?
Sure. At this point in time, we've been very focused on keeping our seniors safe during coronavirus and safe at home. In the coming months, I project that we'll be looking at, as the community opens back up, there's more seniors who are looking at alternatives patients to nursing homes. Maybe that's not where I want to be, especially after the last year, that we're going to be looking at expanding partnerships and looking how we meet the need in Orange County, especially as more baby boomers age into the healthcare system.
Will you have any role to play in the distribution of the COVID vaccine, or is that going to be done by the military or somebody else, or private practice? Are you going to be able to, I'm sure this is being figured out now, there isn't a blueprint yet, but when this thing rolls out, as it rolls out in the next few months and into the spring, will PACE programs be providing the vaccines or administering them?
No, but we're working pretty closely with the county. So CAL OPTIMA, because we're one of the largest health insurance plans in Orange County, we work pretty closely with the county. I actually meet with them every other week talking about vaccine distribution. And so the county is really coordinating that effort right now. And in fact, they're expecting the first 25,000 doses to arrive on December 15th.
Really?
In a few days.
Wow.
That's correct.
We should do a show on that. When December 15th comes, I don't know what day of the week that is, but Dr. Trinh, we should do that when the dosage finally rolls out. We should have somebody on to talk. Who would we
get the shot live on video?
Yeah. Who would we talk to in that program? Can you put us in touch with whoever's going to administer that program here? We'd love to have them come on from CAL OPTIMA.
Yeah, I mean, I can reach out to. Well, I'm at CAL OPTIMA. I'm in charge. I'm running the COVID stuff at CAL OPTIMA.
Okay.
But the county is. I'm working with the county. I work pretty closely with the county on that. The county's coordinating all this.
Well, let's have you come back in a couple of weeks, Dr. Miles, and talk about that as it rolls out. We'd like to be one of the first to talk, because everybody's wondering how, when, who gets it, how do they get it, what happens when they get it. All of that's news. We want to know what's happening right now here in this county, how it's going to roll out, and who's going to get it particularly.
Yeah, we could do that. And I'll tell you, so the first 25,000 doses, they're going to go directly to the hospitals. And so the hospitals for the hospitals to give it to the healthcare workers on the front line.
Makes sense.
So that's kind of the first set of doses. And at the same time, the CDC has a program working with nursing facilities where they've partnered with CVS and Walgreens. And those pharmacies will actually go into the nursing facilities to vaccinate the people who live and work there.
Wonderful.
So that's kind of that's the first group of people who are going to get the vaccine, are nursing homes and hospitals.
Wonderful. All right. What do you think, Dr. Trinh? Should we talk about that when it comes up here in a couple of weeks?
Oh, yeah.
That's
definitely.
only a week or two away. Yeah, exactly. Here.
Next week.
Next week. All right. Well, let's maybe talk to Dr. Trinh, and I don't know who he has scheduled for next week, but let's see if we can get you on in the next couple of weeks here and talk about the rollout of the vaccine. That would be a huge one.
Huge.
Yeah, we could do that.
All right. Thanks so much. Any final thoughts, Dr. Trinh? We'll go around the thing. We'll first say with Elizabeth. What would you like to tell people about PACE that we haven't already covered? What's your final takeaway?
I'd say if you want to learn more about PACE for yourself, for a friend, for your neighbor, our website is caloptima.org, and our phone number is 714-468-1100.
Okay, and that number, once again, operator standing by.
714-468-1100.
Dr. Trinh, final takeaways.
I love it. Love this conversation. Love learning about PACE. We got to get the message out about this program.
Amen to that.
Especially to our doctors.
Exactly. Okay, thanks so much for joining us here today on this latest and greatest edition. This really was wonderful here about Health Talks with Dr. Trinh. You've been listening to Health Talks with Dr. Trinh, the one show that helps you figure out what's really happening with your health today. Right here in Orange County's only community radio station, OCTalkRadio.net.